G'day, I'd like to let you know that Aussie Med Ed is sponsored by Tego. For most doctors, indemnity insurance is one of their biggest costs of practice. While many doctors are still with the same insurer they joined in medical school, many have made the switch to Tego and benefited from it. The team at Tego have told me that those new to private practice could qualify for 4 years of discounted premiums. To find out more about Tego, visit tego.com.au. That's tego.com.au. Whether you're a surgeon, an interventional radiologist, a postoperative physician, or a GP looking after the care of a patient who's had surgery, you may be confronted with a postoperative complication that needs further treatment and intervention. Today we're going to discuss postoperative complications can arise and a pragmatic approach to assessing and treating them. Good day and welcome to Aussie Med Ed, the Australian Medical Education Podcast. A program born during COVID times to emulate that general chit-chat and banter around the hospital with the idea of educating the medical student and GP alike. I'm Gavin Nimon, an orthopaedic surgeon based in Adelaide, and it's my pleasure to bring Aussie Med Ed to you. And today we're joined by Dr DrAshwin Shukla, an Australian-trained geriatrician working with SA Geriatrics, who provides both public and private hospital services to the southern region of Adelaide through Flinders Private Hospital and Flinders Medical Centre and Noarlunga Health Service. He's a lecturer at Flinders University of South Australia, a clinical supervisor and mentor for physician trainees at Flinders Medical Centre, and supervisor for advanced trainees in geriatric medicine. He's actively involved in representing the needs of older people and is involved in research and local lead investigator for the Australian and New Zealand Hip Fracture Registry. Ash is going to talk to us about postoperative complications and his approach to both assessing and treating them. I'd like to start by acknowledging the traditional owners of the land on which this podcast has been produced, the Kaurna people, and pay my respect to the elders both past, present and emerging. Now it's my pleasure to introduce Dr DrAshwin Shukla. Ash is going to talk to us about postoperative complications and the assessment of them and how you treat them. Good day, Ash. It's great to have you here. Thanks very much for coming on Aussie Med Ed. Can you start by telling us a little bit about yourself?
Gav, firstly, thank you for having me. It's a pleasure being here. I've heard some of your podcasts with the other chaps that you've done before, and it's been fantastic. Before I speak, can you give me some idea of your motivation behind doing this?
Well, it all started in about July 2020 when in the midst of COVID, when everything was quietening down. I realised that the students were missing out on the ward rounds. I remember as a student going around on the ward round and seeing my consultants speaking to other colleagues and hearing them chit-chat about other areas of medicine and realised that my other orthopaedic consultants who I aspired to had actually had a fair bit of knowledge apart from just orthopaedics. And I thought it's really a good idea for the students to experience this, even though they're not actually in the hospital. The idea of actually sitting down with other groups, having a chit-chat about different areas, and they can actually realise that it's not just also compartmentalised, but actually everyone has a little bit of other knowledge, i.e. I know a bit about medicine, physicians know a bit about orthopaedics, we've all had a bit of cross-exposure, and realise that actually it's not just one particular area, but it's a team approach. So that's why I thought we'd start the whole podcast series. As it happens, everything started picking up again about the time I started the podcast, and I got busy everywhere. So it's been really quite a squeeze to get everything done, but I still really enjoyed doing it, and I think it's been really well received.
Oh, that's fantastic. It's worked out quite well.
Yeah, it's been great. I've really enjoyed doing it. And to be honest, the number one fan of the whole podcast series is myself, because I actually learned so much out of listening and speaking to other people.
Just coming back to the question you asked me, Gav, about a bit about myself. I'll give you a two-line background. And, I'm Ash, or Dr. Drashwin Shukla. So I've actually been born in India and did most of my medical schooling in India, moved to the UK after that. And I've been in Australia for now the last 16 years. So I've had the luxury of exposing myself to multiple medical systems. It's worked to my advantage in a way. Here in Australia, I've trained and specialized in the branch of geriatric medicine, and I've got a special interest in perioperative medicine. And I think it's probably pertinent at this stage to sort of give a listener the context of what perioperative medicine is and, who can practice it and how do you get into it. And like I declared right at the beginning is I'm a geriatrician with special interest in perioperative medicine, but perioperative medicine per se as a branch has evolved over the last couple of decades because of increasing interest for a number of reasons, which we'll talk about. But as a geriatrician, I'm trained and specialized in managing medical, cognitive, social, more holistic care for elderly patients, whereas perioperative medicine is a more proactive branch that sort of negotiates the comprehensive, holistic, personalized care for a patient from the time a decision to operate is made to the time of discharge and at times even past them. So it sort of takes into account pretty much the whole journey, really, right from preoperative care to an extent intraoperative care and to a large extent postoperative care. So it's a combination of it. And that's why I love it. It's a very empowering journey for the patient as well, and encompassing sort of various aspects during that journey.
And I suspect one of the main advantages of postoperative care is better to see the immediate outcome of the intervention you put in. They start turning the corner quite quickly once you start identifying an immediate problem.
I totally agree. And I think some of this evidence actually came from the geriatrician's involvement in the postoperative care of orthopedic patients, elderly orthopedic patients presenting to hospital with neck or femur fractures. And we've got fairly extensive evidence now over the last decade to say that our involvement in care of that patient population, to be specific, reduces morbidity, mortality in hospital stay, even 1 year mortality by up to 30% in various areas. So there's significant interest involving geriatricians and physicians in general in that patient journey at various levels of evidence-based. And, I think it's important to remember that, we're lucky to be in Australia. We are one of the safest places to have an operation in. The mortality rates on the table are very, very low. And what we tend to forget is we are third in the list when it comes to postoperative mortality. It's third leading cause of death in Australia. So there's, it's in everyone's interest, really, not to just focus on what happens during the operation or surviving the operation, but the quality of life that the patient will be left with after the operation. I think we've moving away anyway from the tradition of focusing on very myopic aspect of the patient care. That's the surgery. But now it's more about starting from the beginning, the decisions made.
Yeah, the hip fracture is a great example because I always tell the medical students that the hip fracture is a complication of a medical problem. And when we present it for an OSCE or other aspects of discussion, we talk about how the actual care of the patient around the hip fracture is the most important aspect, i.e. hydration, creatinine and renal function, looking at the cardiac issues and why they fell, etc. So it's really important to have good care around a hip fracture as well.
That's so true. And, I think that's why geriatric medicine purely from a neck or femur perspective I believe, is reactive medicine. So our involvement in the patient care for those patients is actually after their operation. But the perioperative medicine gives us the luxury, the advantage of seeing the patient right from the beginning of their journey. And there are so many advantages of doing that. It's not just the job satisfaction that we get watching them making those decisions and being aware of what's happening to them and being participants in those decision-making processes, but also there are so many advantages of that process. I mean, I guess the surgeon who's really skilled at what they do and assist the patient in making the decision about the fact that the time of surgery has come and all other alternatives have failed. They come to us with that decision. The advantage for us is we perform a comprehensive medical assessment, not just in relation to the surgery. So there's so many opportunistic advantages of that process where we have opportunities to get them off smoking, minimize alcohol, manage their weight, make incidental diagnoses of a variety of illnesses and diseases. And that is the beginning of the collaboration with the patient and the clinician with a wide range of specialists that they're going to see during the course of their journey, including allied health specialists, nurses, their own GP, their own family members. All of that starts right at that point.
It's interesting to hear a holistic approach to a patient's journey, both pre- and post-operatively. Interestingly, while you've been talking, I've suddenly realised you can conceptualise complications not only into short, intermediate and long-term complications, but preoperative and then short, intermediate and long-term complications, both local and general. And it's a different way of considering complications can occur for the medical student and dividing them up into little compartments so they can remember them.
Absolutely. And I think the restriction in that category is all the elective procedures, I guess. I think we don't have the luxury about doing that, I suspect, in patients that come in with fractures. I'm talking specifically in the orthopedic setting here, but we can take that as any particular setting where cardiothoracic surgery, for example, patients coming with a heart attack. Whereas the relative time difference is also the key, for example, with elective hips and knees, for example, particularly in orthopedic population, versus someone requiring colorectal surgery for colorectal cancer. So the timelines we have to optimize patient care might be very variable. For example, if we find someone in the preoperative setting where we're talking about an elective hip replacement, and who has significant history of smoking or weight gain, the timeline we have to optimize those two areas are probably larger, and we can buy more time to do that. Whereas someone with a colorectal cancer requiring colorectal surgery, we don't have that luxury, so we have to tend to modify our practice. But it doesn't stop us from, identifying those issues and providing the patient and the opportunity to optimize those areas that they wouldn't have thought about. They only come to us thinking that, we're going to come and say yes or no for surgery, but that's not our job. Our job is to empower them. The decision primarily may have been made, but it's just an opportunity to sort out all the other loose ends that they may be in with their health.
And as a perioperative physician, do you find that it's really important to be working cooperatively with the intensive care unit and also with another colleague to help cover yourself? How do you actually manage your time, and how do you actually enjoy a good work-life balance and also enjoy the treatment of postoperative care of patients as well?
Such a good question. And I often, as a medical student in my exam, we tend to forget that we work as a team, and we don't have to do and have to know everything ourselves. We're only a part of the package that the patient is going to need for their well-being in the long term. There is no substitute. As a clinician, my role is to identify the areas in their life that they're going to need care with. I'll sort of cite an example to make it slightly easier. Let's say a patient's coming to see me and they're on 5 tablets, and one of them is a blood thinner, which we'll now start to work towards trying to figure out. We'll need to hold it for surgery because they can't go through the operation with a blood thinner on board. So, the question is, we need to stop the blood thinner. Who started it? Engagement with the person that started it in the first place to understand the implications of what it would mean, stopping the blood thinner or interrupting it temporarily, engaging with the GP and using the right timing, talking to the anesthetist, working out what we would need as a minimum to stop the drug, empower the patient with information about the risks of that approach of interrupting a drug, work out the risk-benefit ratio of that, and move on to the intra and post-operative journey. It's not just about stopping, it's about the timing of restarting it. So hence, talk to the orthopedic surgeon in the process, and then find the opportune time to restart it. It may be during the hospital journey or post-discharge, so engage with the GP again. And, this is just a clinical package of the team that we need to collaborate with to make that one decision. That's very minor. And we talk about psychosocial situation. Where is the patient living at the moment? Where are they going to go after the surgery? What's their physical ability, cognitive ability for them to look after themselves in the post-operative setting? Are they going to need other allied health physicians involved in their care, physiotherapists? Are they going to need discharge planners, i.e. social workers? What sort of help that they're going to need? Are they going to need a step down from the hospital to rehab pathway? Do we need the rehab physicians involved? And all those decisions can actually be preempted at the beginning of that journey, which makes the post-operative journey a lot more smoother. What's the complexity of the patient? Are they going to need an intensive care admission after the hospitalization? Do we need to engage with the ICU consultants as well to make them aware of the patient in hospital so they're armed with all the information that they need even before the day that the patient's in their hospital? So, all in all, teamwork is the key to sort of the right process and the right pathway for patient well-being.
Well, there's certainly a lot to think about in a patient undergoing surgery preoperatively in an elective scenario. Moving on to particular common issues that you might see post-operatively, what are probably the most common things you see?
So I suspect as a geriatrician, the issue that's really close to my heart is delirium. The implications of having delirium in the post-operative journey can be detrimental and can change the pathway. So that's one issue that's really close to my heart. And the incidence of delirium is variable depending on the type of surgery you're undertaking, depends on the type of pre-operative cognitive status. So what are you like on the day, in the months and the years leading up to the procedure? Have you already got a cognitive impairment like a dementia-style syndrome? Do you have any other neuropsychiatric problems and you're on those drugs? Have you had a previous history of delirium with a previous operation? All those things will increase the risk of those syndromes in the post-operative journey. And again, I sort of harp on this, but then it is an opportunity in the pre-operative journey to empower the patient with that information about the risks of undergoing the procedure and the consequences of the procedure and the benefits that they may have by actually having the procedure in the first place and taking on those risks anyway. So in the post-operative period, if the patients do get delirium, the complication rates from delirium are quite high. The incidence of post-operative delirium, like I mentioned, is procedure dependent, depending on minor procedure or major procedure, and the rates vary from 20% to in some cases, even 60%. And the older you get, the more likely you are to get those complications. The approach to managing someone in the post-operative delirium is teamwork, collaborating, non-pharmacological and pharmacological interventions. It's often multifactorial in its etiology. The counseling the family, getting them to understand what is happening to the patient. Often we'd get a family member walk out of the patient room and say, "That's not my dad, Dr. Shukla. That's not my mum. She doesn't behave that way. What's wrong with her?" And counseling is such a key part of patient and family comfort and understanding the postoperative dysfunction syndrome. Focusing on the non-pharmacological strategies, whether it's simple things like, do they have their glasses with them? Do they have their hearing aids with them? Can the family bring in some photos to personalize the environment so they don't feel that they're in an alien environment when they wake up? What medications are they on? Can we swap some of their pain relief drugs? Is it the anesthetic syndrome? Have they had a mini stroke or a stroke during that process? Is pain a problem per se? Is hydration a problem? So all of those things that we as clinicians go through as a process of elimination to take the primary trigger away, to try and minimize the impact of delirium. Because delirium not just necessarily increases in hospital mortality and morbidity, but also it decreases quality of life. It is an independent risk factor for future dementia if they haven't had it before. The risks are about 50 to 80% at the end of 5 years. So it's quite high. Dementia per se is a risk factor for the delirium. So it's like a vicious cycle. So that's an issue that I think I take personal pride in trying to focus on to try and minimize the risk of in the post-operative period.
So interestingly, Ash, with those patients, I always seem to remember everything that's happened after that delirious episode is resolved. How would you actually investigate someone who gets delirious?
I keep it simple. I use an acronym called PINCH ME. It sounds funny, but P is for pain. So is it pain or pain-related medications causing it? IN is for infection. Look for infection, do a blood test, look at a CRP, look at the white cell count, examine the patient, look at the wound. Is it oozing? Are there other areas of infection? Do a urine dipstick, a urine analysis. Do they need blood cultures? Are they febrile? C is for constipation. The other thing that we conveniently tend to ignore in hospitals. We're so focused on getting them rehabbed and pain managed, we forget constipation. So are they constipated? When did they last open their bowels? Are they on the right tablets to get their bowels open? H is for hydration and hypo or hyperthermia. So are they febrile? Are they hypothermic? Are they well hydrated? Again, clinical exam, blood tests, look at the creatinine levels, look at the urea levels. And M is for medications. Again, rationalize medications, optimize medications, and E is for electrolytes. So as a part of the day one post-op journey, my routine practice is to get a blood profile, a full blood count, an EUC and a CRP, and then add on the other battery of tests depending on what I think the primary problem may be driving this.
So the CRP obviously would be elevated following surgery, but that's as a baseline to compare to make sure it doesn't increase or decrease.
It's a really good question, and I think you're absolutely right. I personally use it as a reference point. I don't think there's any evidence to back my pretest probability. I don't judge it. I use it as a reference point. And it isn't routine practice to do that, and most perioperative physicians may have a different opinion on that. But that's my personal practice to try and help me monitor their progress, if it goes backwards especially.
Okay, so delirium is obviously a really important issue, but another complication I see a lot of in the postoperative period is nausea. Is that a major issue for the patient, and how do you investigate that or treat it?
Absolutely. And I think the incidence of postoperative nausea is about 20 to 40%. Yes, it's a very common complication in the postoperative period. And diemetics as a package in the postoperative protocol to manage it is going to be crucial, because I'm sure you have and I have at some stage in our lives been nauseous and vomited. It's a horrible feeling, and it's no worse feeling to have in terms of mental well-being and how you feel about your own health than being nauseous and vomiting. So it's a really important factor to manage and control in the postoperative journey. So that's the commonest sort of issue in the first 24 hours. We don't see it as the anesthetic wears off, which is typically anything between 12 to 36 hours. We see that the incidence of nausea and vomiting dramatically drops, sort of pointing to the fact that type and choice of anesthesia is also important, and also an important factor that causes the nausea in the first place. That said, though, in the later stages of the journey, if they develop nausea or vomiting, we always need to monitor for bowel action, keep a cautious eye on making sure that they don't go into pseudo-obstruction or full-blown obstruction. The other causes of nausea during that period may be medications. We often use fairly potent pain relief medications, and patients may be naive and would have never had them before. So that might be another cause that maybe lead to it. So depending on the timing of when they get it and the relief from the medications that they may get in terms of nausea medications, I think my threshold for starting them on antiemetics is quite low because it's quite manageable, part of their pathway. And I think it's an important thing to remember to prescribe as a postoperative, in their postoperative journey, just to arm the nurses with the medications they may need to manage it.
Ash, what antiemetics do you tend to rely upon? When I was going through, I knew Maxilon as the main treatment we used. I'm not sure if that's the main treatment nowadays or there's better ones available. So what would you recommend?
That's a good question, because I think the goal is to minimize nausea vomiting. It's not, the evidence is driven towards managing the syndrome rather than the drug used to manage it. So and every country that I've been through seems to have a different agent that they use. I personally use ondansetron or tropicitron as the first line because they come in a wafer form. You can give them intravenously if you want to. If IV access is an issue, Maxilon's equally useful because you can give it intramuscularly as well. But ondansetron seems to be the popular choice in Australia that can be given 3 times a day, even if needed, with the second line being Maxilon.
And how do you watch for paralytic ileus? I know it was relatively common after hip replacements, I believe. What are the assessments? Is it purely bowel sounds and bowel movements, or are you looking at electrolytes as well as part of that?
Correct. All of the above, as you would imagine, as a multi-system assessment when we see them in the post-operative setting. So yes, the bowel action is key. So we keep track of when they're opening their bowels, incidence of nausea, vomiting again, and the first post-operative blood test, all of those together. And at the end of the day, we don't treat numbers, we treat patients and we treat people. So if they feel nauseous and vomiting or have abdominal pain or haven't opened their bowels, then that's a prerogative to step in and be proactive to manage that.
Another issue that I see is also the patient with diabetes, both type 1 and type 2, managing them both preoperatively and how you hold the medications and then postoperatively as well. Any tips for that as well?
It's a very common issue that we're going to face, I guess, over a lifetime. Our patients are getting older. Almost 50% of patients nowadays come into hospital sometimes have their surgeries are diabetic, and they're all classified in the high-risk category. I actually heard your podcast that you did with Dr. Maya on diabetes. That is fantastic. And, I suspect there are lots of insights in there for people who want to use it. But generally, the principles remain the same. Don't deny type 1 diabetics their insulin, minimize fasting periods, and try and aim for goal sugars between 6 and 12 to keep it very simple.
I guess a lot of the sliding scale insulin regimes are already established by the local hospitals that the intern might be working at. But do you have any tips in particular regarding sliding scale insulin doses or levels of BSLs you should be aiming for, etc.?
I traditionally accept anything up to 10. So I go 0 to 10, nothing. 10.1 to 15, 2 units, 15.1 to 20, 4 units, and greater than 20, I give 6 units of NovaRapid or ActRapid, short-acting insulin with meals.
What about fluid write-ups? What would you recommend as the post-operative fluid maintenance dose you should write up for a patient, both diabetic and non-diabetic, in the post-operative period? What would you recommend for someone who's got normal renal and cardiac function?
The key is hydration. So any isotonic saline is adequate. In the postoperative period, just 0.9% normal saline, enough to keep them hydrated, especially because of their preoperative fasting period and likely postoperative recovery period when they're not going to be eating and drinking much. Making sure it's adequate amount of isotonic saline. So you would imagine the intake to be between 1 to 2 liters at least over a 24-hour period. And most patients that come to the wards have already had orders from the anaesthetists about a choice of their fluid agent on board, and it's traditionally been 0.9% normal saline over 12 hours, 2 bags, something on those lines.
Okay, let's say someone has had bowel surgery or they've developed a paralytic ileus and has had to go on nil by mouth, and they've been going for this for, say, 24 hours. Does the fluid maintenance change in that way? And do you add potassium to your fluid orders as well? And do you choose a different substrate?
It depends on the electrolytes at that stage, I guess. You need to be closely monitored, I suspect, because, like you said, the electrolyte imbalance plays into the ileus and vice versa. So I think it's all guided, the very personalized approach towards managing their fluids based on their electrolytes, no generic recommendation.
Excellent. Another issue which we occasionally see is someone who develops chest pain postoperatively or gets an arrhythmia. Both are probably very similar scenarios. How do you investigate that and treat that?
The default position on the wards for someone with chest pain appears to be cardiac in its origin, and it's very reasonable to start on that point. And every hospital has a protocol to manage someone with chest pain, whether it's initial treatment by the nurses and calling a doctor on call or calling an emergency or a med call or a code blue, whatever the protocol may be. So what the whole idea is that these patients need to be looked at quickly, because there is a chance of something life-threatening happening here that we need to substantiate, and it may be a process of elimination, and it needs to lead into some prompt investigating to rule out anything life-threatening before we move on to more other benign causes for chest pains like musculoskeletal or reflux, for example. You have to always assume the bad things first. That's one area of medicine that we're told well, how to manage someone with chest pain. Prompt assessment, clinical examination, and ECG is probably the quickest things you can get. And we used to talk about MONA in the old days, vein, oxygen, GTN. Yeah. So now we approach them with clinical exam, ECG, and a blood test to look at troponin and see how they respond to initial GTN. And it sort of relies on a clinical history about the type of pain. And I guess the pre-test probability as well, in terms of what comorbid diseases they've got with them. Someone who's type 2 diabetic and previously known ischemic heart disease with a stent, who's anticoagulants, antiplatelet therapy has been interrupted for surgery and get chest pain. Your suspicion of a cardiac origin is going to be quite high. And then the second half of the picture is, whether it's very common for an hospitalized inpatient, no matter what the trigger for the hospitalization is, whether you're medically unwell or whether you're surgically unwell, or whether you're the post-operative patient, that the deep vein thrombosis is a common complication. Even more so in the substrate of orthopedic populations, we're having knee and hip replacements. And I guess it's also important to realize the implication of having a pulmonary embolus, as the mortality risks of untreated PE are exemplary high. So I guess someone who's 65 but has got no cardiac history and has got a long bone fracture and post-op, and at day 5 you develop chest pain, your level of suspicion then goes down the pulmonary embolus path. But there's no substitute to clinical assessment, examination, ECG, and taking a good history. And depending on your level of suspicion of one diagnosis over other, if you think that the patient may be having a pulmonary embolus, do not wait for confirmation of the diagnosis. Start treatment with therapeutic anticoagulants immediately if you don't have access to urgent imaging, while you wait for the imaging to confirm the diagnosis. And on the flip side, if you feel that the cardiac syndrome and ischemic syndrome is more likely, escalate their care, both from the site where they're at, are they in the right setting? Look around you. Are they going to be a monitored bed? Are the cardiac nurses looking after her? Has their pain resolved? Do they need monitoring? Do they need to go to ICU? Are they showing an arrhythmia that you need to deal with at the time? Get help. Call your specialist colleagues, with the registrars on the cardiac section or the consultants, whoever you can access.
So once you've given pain relief, analgesia, and organised further monitoring, what's the definitive investigations that are performed for either cardiac ischemia or for pulmonary embolus?
The primary concerns and cardiac ischemia, they go straight to an angiogram. It's to have an angiogram, to look at the clot that they can potentially assist working out, or that they can dislodge. And with the pulmonary embolus setting, I guess it's important to remember the CTPA and the VQ scan are both equally efficient in picking up the clot. Just that the CTPA will give you the added advantage of working out if there's something else going on. There isn't a clot, like infection, for example, or pleurisy. As that's the only advantage of the CTPA, and that's probably more readily available the nuclear medicine scan, depending on where you are.
Okay, what about the development of an arrhythmia such as atrial fibrillation, say in a patient that hasn't had a history of atrial fibrillation in the past? Is there any difference in the investigations and treatment of that for sudden onset of chest pain, or is it more straightforward?
Look, no, not really. And I think it's interesting you bring that up, because I think the arrhythmias can be a manifestation of a pulmonary embolus or underlying cardiac ischemic syndrome, and also be an independent arrhythmia by itself. So I guess it's important to remember when you're looking at a new arrhythmia in the postoperative period to always think about those bad things that we talked about that could be potentially life-threatening, the pulmonary embolus and the cardiac ischemia. Think about those things as you go along to manage the common arrhythmias like atrial fibrillation. And you're right, it's quite common in the postoperative setting to get atrial fibrillation. And I guess that boils down to the type of procedure you're having. If you're having a cardiothoracic procedure, a valvular procedure, very common. Whereas if you have a non-cardiac procedure, less common, but not unusual. When we're talking about teamwork, I think it sort of brings the point. Let's say you get the atrial fibrillation in a day one neck femur fracture patient. The questions need to be asked. We have to restrain our impulse from jumping in and giving them anticoagulants, but collaborate with the cardiologist, the surgeon, talking about the risk benefit of getting the medication at the time that you're going to give it to them, about the bleeding risk from the wound. What are the risks of that versus what are the risks of them having a clot? So we traditionally use different scoring systems to try and ascertain the risks of developing a clot, i.e. a stroke from atrial fibrillation, and then we balance that against the bleeding risk. So it's going to be a team question about what's the right thing to do for the patient in collaboration with 3 specialists.
Brilliant. Well, moving on, another complication I've heard of is renal impairment, either related to dehydration, both pre or post-operatively, or related to medications, or a combination of both. Is this still as common as it used to be, or is it less common now that we've got post-operative physicians keeping an eye on these patients?
I think the awareness seems to have kicked in, Gav. I think the incidence appears to be lower than what previously has been seen, although it's my observational evidence rather than hard and fast randomized control trial. But I guess the postoperative renal dysfunction is an important factor to rule out, especially on the day one bloods, because it impacts on pretty much everything you do. The kind of pain relief you give them. Are those drugs going to be renally excreted? Is that going to accumulate, make them drowsy? What is the post-op blood pressure? Is it low blood pressure? Is it just hyperperfusion injury to the kidneys? What were the preoperative medications? Are they on drugs that are nephrotoxic? Like the commonest one is the ACE inhibitors and the ARB drugs for hypertension that we tend to use. Do we need to hold them for a little bit? Do we need to monitor their renal function in the postoperative period? And again, it's sort of the luxury sometimes we have of a preoperative assessment is the reference point, the optimization, the rationalization of these drugs, and predicting some of this in the postoperative journey. Just to summarize, renal dysfunctions are not uncommon. It's important to identify early in the piece and monitor its improvement and rationalize its treatment based on the possible trigger that may be causing it.
Okay, and with the exception of checking the blood pressure, keeping an eye on the medications, watching the urine output and checking electrolytes, is there any other investigations you might need to perform in this scenario to watch out for renal impairment?
I guess we can't forget the usual and the common things that we would normally investigate. The reactive assumption is that it's probably a post-operative dehydration-related injury, which is the commonest reason usually. But at the same time, we can't forget the usual suspects, I guess, doing a urine dipstick and sending a sample off. There are other things that we could go dive in and dig into, especially if the renal function continues to get worse, despite usual tactics to try and mitigate them getting worse, i.e. holding the drugs, giving them fluid, and ruling out infection. Then have they had direct toxicity or an injury? Or is there a pre-existing diagnosis that we weren't aware of that's developing in the mix? Do we need to look for casts? Is there blood in there? Have they had prostate issues? All of those questions sort of start to get more relevant and bigger if especially the renal function continues to deteriorate despite simple measures and ruling out simple suspects.
And of course, in the orthopaedic patients, I'm aware of antibiotics and non-steroidal anti-inflammatory drugs being an issue and causing renal failure. Is that a common scenario in patients in general, or is this something that's less common and not as big an issue nowadays? I'd like to let you know that Aussie Med Ed is supported by HealthShare. HealthShare is a digital health company that provides solutions for patients, GPs and specialists across Australia. Two of HealthShare's core products are Better Consult, a pre-consultation questionnaire that allows GPs to know a patient's agenda before the consult begins, with the aim to reduce admin and free up time during a consult, and HealthShare's Specialist Referral Directory, a specialist and allied health directory integrated into GP practice management software, helping GPs find the right specialist. You can find out more from healthshare.com.au.
Interesting you asked that, Gavin. When we talked about this medication rationalization, one of the medications we need to rationalize in that setting is the non-steroidal drugs. I mean, there's no doubt and there's enough evidence to support the use of non-steroidal drugs in the post-operative setting in the short term, that the benefits are high. And that's sort of been shown to my surprise that even the elderly population, a short-term use of non-steroidal drugs in the right setting, in the right patient, in the post-operative period is the right thing to do. I used to protect my older patients from non-steroidal drugs for the longest of time. So I had some recent evidence shown to me that it's quite safe for the short term in the immediate perioperative context. But yes, that's definitely one of the drugs we look at with suspicion and definitely hold it to avoid any further toxicity to the kidneys if that's on board. But traditionally, they're reasonably safe to use, again, in the right patient, in the right setting, for the right procedure.
Yeah, I think they've been shown to be given quite good analgesic effect.
Correct. And they're opioid sparing as well. So, there's a catch-22 because we want to try and minimize opioid use in the post-operative period as well. So they are quite, like you said, provide good short-term analgesia. But I guess the challenges with those drugs are not just the kidney ones, but the GI side effects, and someone taking ownership of making sure that we specify the duration of time that they need to be on it for, talking about teamwork and involving a pharmacist and making sure there's a discharge medication list that the GP gets so it doesn't become another drug on their long-term medication list. I guess that's probably the only thing we need to guard against and choose the patient. When I say patient selection, I meant making sure that they don't have a history of significant reflux disease or previous GI ulcers and bleeding risk from that perspective.
What about hypertension or asthma? Would that stop you using a non-steroidal for pain relief in the post-operative period for a short term, or is that just a long-term issue?
Non-steroidal drug use in asthmatic setting depends on whether it's an NSAID-induced asthma as a primary diagnosis of the etiology of the asthma. It's not a common syndrome, but it's really important to be aware that maybe a syndrome in the mix which would make you guard against using them in that particular type of asthma, but otherwise not really. In hypertension, it's funny because I think what tends to happen, Gavin, the postoperative period is the pain itself is a usual driver for the hypertension rather than the pain relief drugs. So if someone's in pain and you hold the drugs because you think that you might affect the blood pressure, that's more counterproductive than actually giving them the drugs and helping them manage the pain and manage the blood pressure. So the flip side is actually true. You need to manage their pain well, and that'll help manage the blood pressure well. And in the first 48 hours in the post-operative period, depending on the choice of the anesthetic, what we often face is post-op hypotension. Post-op hypertension is a not as common syndrome, but the pain sort of sometimes can drive it up and down. It can fluctuate. And that's probably one thing I want to sort of highlight here, that not judging blood pressures in hospital to start or cease a medication management plan for blood pressure management. So what I mean is if someone's got blood pressure issues before they come to hospital on regular medications, they come to hospital, have a low blood pressure, so we hold it. It's important that at some stage during their journey, in 5 days to 2 weeks mark, that the physiology is going to return to normal. So we need to then communicate with the local practitioner about temporary interruption of these drugs until blood pressure is reasonably up so that they can be restarted at an opportune time. And the flip side's true as well. So if they're hypertensive in hospital, the key is to guard against start new medications aggressively unless they've got any end organ damage as a result of that hypertension, and send them on more drugs when they go home, only for their physiology to return to normal. And those drugs that you started in hospital too potent for them, and that they become hypertensive and dizzy when they're out of hospital. So the blood pressure management fluctuation is something we just need to acknowledge and bear in mind the repercussions of either starting or stopping drugs in a hospital.
On that basis, and thinking about the medical student or young intern that's just started who might be called to see a patient who's got high blood pressure, what level of blood pressure do you accept, and what numbers do you actually worry about that may cause a complication long term in the acute setting?
Well, we come to the number after the symptom. Is it an incidental blood pressure that they've done, or is the patient having headache? Is the patient having nausea, vomiting, and the blood pressure is 190? That's different to an incidental finding. So if they have an end organ problem that you've been worried that the blood pressure may be contributing to, then even a blood pressure of 170 and those symptoms you need to take seriously. But if the patient's asymptomatic and the nurse has come on their 4-hourly ward round and done blood pressure and it's 180 by 17 that they've called you, all you have to do is reassure the nurse. I usually accept blood pressures under 190 systolic, and my job at that stage is to acknowledge it, reassure it, and check for any symptoms suggestive of end organ damage.
And obviously you'd want to check your blood pressure yourself, but you'd also advise the nurse to recheck it in hourly or 2 hourly, or just another 4 hours would be appropriate?
It's a good question, and it depends on the circumstances. And for example, if there's a patient with a significant history of end organ damage, cardiac disease, history of stroke, your level of concern would be different. So, what questions you ask when you get that phone call are going to be crucial to that decision about what to do next. I would probably tell the nurse to check it manually in the first instance and make sure that it's a manual blood pressure, because machines cannot be reliable. And yes, recheck the blood pressure as routine if they're asymptomatic and are low risk.
Well, we've covered a lot of ground, and I'd like to finish off by asking your approach to treating a patient who's been struggling at home, has been admitted to hospital, usually in the setting of an emergency scenario, and is identified that they may struggle to return directly home. What are the options in Australia, and how do you deal with assessing these patients, and where do they go from an acute setting into a home situation? What's the transition period you can do, or transition approach you take?
Yeah, that's such an important question, because we're so focused on the postoperative journey that discharge planning needs to start from the day we see them preoperatively in the clinic and at their first visit, and start to have our minds and our ears open to all possible pathways and outcomes. So traditionally, the way we see things in hospital is the first 48 hours, no matter what you're in, because of surgically speaking, it gives us a window or a graph of an opportunity to see what their physical ability, cognitive ability is going to be, to start making some decisions in collaboration with the physiotherapists, occupational therapists, speech pathologists, dietitian, nurses, as a team, to get a sense of the graph that you're building, and get a sense during that time, if you haven't already, to get a sort of robust psychosocial history. Traditionally, we'd see pathways of either a hospital to home with no support because they've actually recovered spectacularly. We'd see pathways of hospital to home with support that could be organized as outpatients, whether it's physio or other allied health. And then the more other pathways would include from hospital to rehab, and a variety of rehab options, whether it's short-term or long-term, to give them more time to recover from the insults of their operation. If they need physical and functional rehab as a dominant issue, then they go to traditional rehab facilities. And if they have a cognitive post-operative dysfunction, then they would go to a unit called GEM, or Geriatric Evaluation and Management Unit, which is geriatrician-led. And the third pathway in the journey is, look, it appears that their rehabilitative potential, for whatever reason, isn't going to be favorable for them to return home. And then we start to navigate through the maze of the aged care system and try and assist the families in navigating that pathway to get them into a residential care accommodation, whether it's respite, which is short-term, or permanent, which is full-time residential care, of course. And that all sort of pans out over the period of 2 to 5 days in the post-operative period. It becomes very apparent depending on the nature of surgery.
Brilliant. And obviously there's whole teams involved in that, and it takes a bit of time to get that coordinated. At least there's all different options depending on the different scenarios.
Exactly right. And I think teamwork's the key. And as a geriatrician, I take pride in collaborating, being open to team environments. I think anyone taking on the journey towards becoming a perioperative physician needs to have a good team, and I'm lucky that I have a good team around me that I can bounce off, and we can brainstorm and come up with the right decisions which are patient-centric. I think we're lucky that we live in a day and age gap that young physicians who are budding will have the opportunity to specialize in perioperative medicine rather than just have a special interest, because it's become a branch of its own now. And Monash University, for example, offers a 3 years master's in perioperative medicine, and that's taken on with glee from physicians, anesthetists, geriatricians alike. So, you can be from any walk of life and want to do it, and you can get access to it. The Royal Adelaide Hospital does a perioperative medicine registrar course that has clinicians with special interest in training them, giving them exposure to those settings and those journeys. And evidence is evolving all the time to support that collaborative approach to care.
That's fantastic to hear. Look, I really appreciate you coming on Aussie Med Ed. It's been a fantastic time. It goes quickly, actually. We've covered a lot of ground. And it's been excellent. So, look, thank you very much, Ash. It's been great having you on board.
Thank you for having me, Gav, and I wish you all the best, and I'll see you around.
Thank you very much. I'd like to thank you very much for listening to our podcast. I'd like to remind you that the information provided today is just for general medical advice and does not pertain to one particular medical condition or one way of treating a particular condition. If you have any concerns about information raised today, please do not hesitate to contact your general practitioner for further information. We hope you've enjoyed the podcast, and please don't hesitate to give us a like or tell your friends about it or give us a positive review. We look forward to presenting another podcast to you in the near future on a different topic. Until then, stay safe. Thank you very much. Aussie Med Ed is proudly sponsored by HealthShare, a digital health company that provides solutions for patients, GPs and specialists across Australia, and Tego, offering medical indemnity insurance for doctors. That's tego.com.au.